Clostridium difficile, beyond the usual suspect. Clostridium difficile, the silent killer.
Clostridium difficile is one of the bacteria that can cause severe antibiotic-associated diarrhea. It can be debilitating. It's usually treated with antibiotics, and the antibiotics usually cure anywhere from 50 to 75%. But it's recurrent in the illness. It keeps recurring. It's very difficult to treat.
Without the protection of our normal bacterial flora, an overwhelming growth of C. diff can cause serious complications.
Between 15 and 30,000 people a year die of Clostridium difficile in the United States of America. More people are dying of C. diff in the United States now than are dying of HIV. The question is there data to say that probiotics can prevent this? Well, there's growing data. There's now 2 major papers. One of them is in the British Medical Journal, and a bunch of little papers that say we can at least decrease antibiotic-associated diarrhea. I mean, the newer ones are showing we can actually decrease C. diff now by just giving pennies a day worth of probiotics. In our hospital, everybody gets an antibiotic as an option of taking some yogurt too.
One of the central concepts guiding of efforts to prevent Clostridium difficile infection has been that symptomatic patients in hospital are the major source of transmission. Infected patients with diarrhea shed large numbers of spores, contaminating their skin, clothing, and surface. Measures to prevent transmission. They include placement of infected patients under contact precaution until diarrhea resolves, the disinfection of surface on equipment with sporicial products such as sodium hypochlorite. Unfortunately, these measures have often proved to be ineffective during the past decade, when infection rates have risen dramatically in association with large outbreaks of different strains of Clostridium difficile. Are we missing important source of transmission? The difficulty in controlling Clostridium difficile has raised several important questions about traditional models of transmission. For example, asymptomatic carriers of toxin-producing strain of Clostridium difficile outnumber infected patients, but their role in transmission has been uncertain. Toxins.
Difficile is a bacterium that causes infections of the colon, typically in elderly hospitalized patients. The bacterium secretes large protein toxins that cause disease symptoms such as diarrhea, colitis, and toxic megacolon. The toxin binds to colon cells via its receptor binding domain and is internalized by vesicles called endosomes. Acidification of the endosome leads to translocation of the protease domain and the enzymatic warhead into the cytosol. Inositol hexakisphosphate, or IP6, present in the cytosol, binds to the toxin and activates autocleavage, thus releasing the enzymatic warhead of the toxin into the cytosol. The activity of the enzymatic warhead disrupts the cell cytoskeleton, leading to cell death. The antibiotics currently used to treat the infection do not inhibit the action of the toxins. Therapeutic agents that neutralize the toxins in the colon before they can penetrate cells, therefore have high potential to reduce the burden of C. difficile infections.
Are we underestimating the proportion of cases acquired outside the hospital? No hospital is an island. Increasingly, patients enter and leave hospital colonized or infected with Clostridium difficile. In the United States, as many as 75% of infections have their onset in long-term care facilities or the community. The administrations of antimicrobial agents during a previous hospitalization is a predisposing factor in many of these cases because antimicrobial-induced alteration of the intestinal microbiota increases susceptibility to infection for several weeks. In addition to long-term care and outpatients healthcare settings, other potential reservoirs outside the hospital include colonized infants, food, and animals. Are there symptomatic patients in hospital, the ones who accounts for most Clostridium difficile transmission and infection? Several investigators have found that nosocomial transmission from symptomatic patients may account for a minority of cases. Many patients with symptomatic infections have been missed by the relative inceptive testing method used. If strains are hospital-acquired potential reservoirs other than identified patients with symptomatic infection might include undetected symptomatic cases, asymptomatic carriers, and environmental contamination. The control of Clostridium difficile will require that we move beyond the usual suspect.
C. diff is a bacteria that causes inflammation of the colon, which is called colitis. Toxins produced by C. diff attack the intestinal lining. Those at high risk for C. diff are elderly patients, usually over the age of 65, patients with recent hospitalizations, and patients that have had recent antibiotic therapy. C. diff usually occurs as a three-step process. In the first step, the destruction of normal flora, the current antibiotic may have killed good bacteria along with the bad bacteria. In the second step, the patient will usually ingest the C. diff bacteria. Now, this is usually done while they're in the hospital, and the spores can be very abundant in the hospital environment. In the third step, the patient will usually develop a C. diff disease. The usual incubation time is approximately 7 days. The signs and symptoms of C. diff are abdominal pain and cramping, watery stools of 10 to 15 per day, dehydration, fever, renal failure, and pus or blood in stool. Tests done usually to diagnose C. diff would be stool cultures. Keep in mind that these can take several days to grow. And then a colonoscopy or a sigmoidoscopy. Current treatments include trying to stop the current antibiotic that triggered the illness to begin with if possible. Start a new antibiotic to combat the C. diff bacteria. This is usually Flagyl or Vanco. Surgery may be needed to remove part of the intestine.
Thank you.